Good afternoon, everyone. We're going to go ahead and get started. Welcome to the Professional Satisfaction and Practice Sustainability Fall Webinars. Before we begin, we wanted to quickly review some housekeeping items. This session will be recorded and will be available after the event. If you have any questions, please place them in the Q&A box below. We will have time at the end of the webinar to answer many, if not all, of the questions. Without further ado, let's go ahead and get started with today's webinar. Today's speaker is Dr. Jonathan Ripp, who's the Chief Wellness Officer at Mount Sinai Health System, Dean for Wellbeing and Resilience at Icahn School of Medicine at Mount Sinai, and co-chair for CHARM, which stands for Collaborative for Healing and Renewal in Medicine. Today, Dr. Ripp will be presenting on healthcare workforce well-being in the wake of COVID-19, lessons learned from the Mount Sinai experience. Welcome, Dr. Ripp. It's a pleasure to have you.
Thank you so much. It's really great to be here. I'm delighted to have the opportunity to share with you all what it is that we've been through recently and how it informs our thinking around the ongoing discussion related to healthcare workforce well-being. So what I hope to share with you today falls into these objectives that you see. We're going to consider how the COVID-19 pandemic impacted the emotional well-being of the healthcare workforce, specifically speaking to the experience that we had in New York City, where we were the initial epicenter for COVID-19 in the US. Obviously, at this point in time, it's pretty much everywhere, but when we were experiencing it in New York City, particularly back in March and April and May, it was particularly significant there, and so I will be sharing with you a bit about that. In so doing, I hope to identify some changes needed to physician well-being initiatives in this sort of new normal that we all speak of, and then make the case for continuing to prioritize physician well-being under the present circumstances. At the end, I do hope that you'll be familiar with resources available to address these stressors and other well-being needs. What I have for you here is the model that we use at our own Office of Wellbeing and Resilience. It's our model of healthcare worker well-being. It will look familiar to many of you. It borrows heavily from existing models and is not really intended to be, sort of our own special model that we're trying to espouse, but rather we went to a lot of effort to create this for our own purposes. We wanted to be able to speak a coherent message within our health system and share amongst us what it is that we believe contributes to professional fulfillment and meaning in work. Really, what we're trying to see here as our main outcome of interest. And so you can see that these wheels all turn towards that outcome. And it's not an accident that some of them are larger than others. We really, like most of us that are deeply invested in this field, we really do think that it's the system level drivers that largely have an impact on the outcome of professional fulfillment and meaning. And so you'll see areas focusing on workplace culture and workplace efficiency and function are sort of larger and represented in a larger fashion, because we do think those are the domains where we can have the greatest impact and where we want to dedicate our energies. You'll note that the workplace efficiency cog there is just slightly larger than workplace culture. And one of the things I do want to convey with you all is how there's been a little bit of a shift in thinking with regards to that. What I've done here for you, and we haven't actually done this officially yet, but I've sort of shifted those, the size of those components. And it's my belief that particularly within the context of COVID-19, the impact of workplace culture may just be edging out in terms of the amount of impact it can have on the well-being of the workforce. And so, these are well-known and elements that contribute to workplace culture are well-known in terms of their ability to have great impact on well-being. But what I want to convey in the next few slides is how our experience sort of shed light on just how important it is. And also in moving forward, there are a host of challenges that the healthcare workforce and the healthcare systems currently are facing, where it might actually make sense to somewhat shift the attention a little bit more so to efforts that address workplace culture. So this slide almost certainly is familiar to many of you joining us today. It's a great figure by Shanafelt and his group, which captures how job burnout, as really one means of measuring well-being, has its impact both at the personal and professional level. I sort of provide this just for the reminder of the context within which we're having this discussion, this talk. In that there are these personal consequences of burnout, such as depression and substance abuse, even suicide, as we all know, the most tragic consequence. And then, of course, there's the impact on the healthcare system. And so the professional consequences of not addressing the well-being of the workforce impact things like quality of care, medical errors, patient satisfaction, productivity, professional effort, and of course the retention of the workforce that physicians have been shown to leave more likely to leave their jobs if they're burnt out. So of course, this is the context prior to COVID that really helps to make the case for large-scale efforts to address well-being. In the midst of the pandemic, we saw some additional stressors, and that's what I hope to convey to you here. And those stressors, in a way, they sort of became most prominent in parallel to the stage of the pandemic curve. So what I mean by that is certainly our experience in New York City was such that in early March, just as the first cases were coming in, when we recognized that we were dealing with a significant problem that was heading our way, it became clear that everything was going to be changing. It was that fear around basic needs that emerged as a major source of stress. And so as society became disrupted, we began, as a community to ask ourselves, how are we going to get to work safely? Who is going to take care of my children? Things as simple as am I going to get the next meal? Issues around transportation, issues around concerns about keeping ourselves and our loved ones safe. Will we have the right equipment to be kept safe in the midst of this pandemic? Will we have the right equipment to prevent the spread to our loved ones after we come home? And those were some of the primary stressors at the beginning of all this. As we began to enter the surge phase and really into April, when we began to see in our 8-hospital health system at the height over 2,000 patients with COVID in our health system, as we began to surge up to that peak, there was an enormous amount of uncertainty that surfaced. And that uncertainty was exemplified through issues such as, how long will this increased workload continue for those that were in the midst of it? Will I be able to do my job effectively? Will I have the resources? Will I have the know-how if I'm redeployed? For some folks who were actually doing less work because their clinical spaces, such as some ambulatory spaces, were closed, they were faced with the guilt of asking themselves, am I doing enough in the midst of all this? And of course, there were concerns expressed about whether we'd be supported. Will we be able to make difficult decisions if they're asked of us? Decisions that a lot of us feared around the possible limitation on resources. As we then led to the other side, the downward slope of the pandemic curve, we began to enter the period where we could process what it was that we had gone through. In the midst of it, people are often, healthcare workers are often very much focused on the job at hand. But what's clearly been demonstrated and spoken of, and is our experience, that as those numbers of cases began to fall, that was the time when people could take a breath and then process what they had been through. And nobody in our community had been untouched by this pandemic at that time. There was grief and loss at multiple levels, some quite personal. And that was a very difficult, obviously continues to be a very difficult time. It was also a time when we began to fear about some of the psychological consequences on the workforce, concerns about PTSD, and it just happened to overlap with the beginning of the societal upheaval and attention to racial injustice that we've all been paying attention to. And so it just layered on at that period of time and continues to, of course, multiple levels of stress. So on the next slide, what I show for you is how we addressed those individual level stressors. So as it relates to our strategies as a health system to address these stressors as they came up, and I don't want to give the sense that, it was at one stage, it was just one source of stress and then it transitioned entirely to another, but this is merely to give you a sense of some of the larger stressors that were present at given periods of time. So when it was about a fear for basic resources, we made sure to provide for those basic daily resources. Things as simple as providing free and subsidized food, clarity around the availability of personal protective equipment, resources for childcare, transportation, parking. A lot of efforts went into effect to provide for those daily needs. At the time when uncertainty became the primary source of stress as our patient cases of COVID were rising steadily, it was really critical to focus on regular, authentic communication. I would go so far as to say that because of the great deal of uncertainty that we all are experiencing at the present time, that this again has emerged as a critical need to provide regular communication in multiple ways. For folks who are communications experts, it's clear that for certain topics, you probably can't over message and you probably need multiple ways to get the message out. We accomplish this through all the usual means, through town halls, through regular emails, through transparency, through the content that was authentic, and through some weekly wellness messaging that my team helped develop. And then as the concerns about processing these experiences, the grief and loss, and now as we've entered the post-acute disillusionment phase that has previously been characterized, layered on by a number of additional stressors with the reopening of school and the reopening of businesses, there's a continued and ongoing concern and need to provide robust and comprehensive psychosocial mental health resources. We've accomplished this and put up in rapid fashion a number of resources in the midst of the pandemic, and continue to provide a number of these resources, such as virtual support groups. We had to change the mechanism by which we delivered support in group-based fashion to virtual formats. Phone lines, at a given time, we had a 24/7 crisis line. We still have round-the-clock phone support, telepsychiatry, proactive measures, which we dub mental health PPE, a very important effort to actually proactively reach out to the healthcare workforce, recognizing that not everyone will seek help when needed for a host of reasons. That's an effort that we continue to highlight and have concern about. And then what we referred to as frontline relief, to providing support in the workplace, to provide areas to rest and recharge that were located on site, particularly in the midst of a crisis when the ability to move freely, given infection control issues, was severely inhibited. With some colleagues at Stanford who conducted focus groups there, and through the information that we gathered through our well-being infrastructure at Mount Sinai, which is a host of individuals embedded within a variety of levels and spaces across specialties and work position, whether it be nurses or physicians, trainees, students, etc. We gathered and captured this information and published it in this JAMA piece back in April, where you see that we captured what it was that the sources of anxiety were, and what it was that healthcare professionals were really asking for. And it boiled down to a lot of sort of basic human needs that in times of stress, if you look on the left side of this figure, people, folks in the workforce rather, they're asking to be heard, to be protected, to be prepared, to be supported, and to be cared for. This is really what the themes were that we understood as we captured this. In another piece that our group published, we captured the larger comprehensive effort that I'm speaking to you about today in a piece titled "Attending to the Emotional Well-Being of the Healthcare Workforce in New York and a New York City healthcare system during the COVID-19 pandemic." And this speaks to the sort of total effort in those major strategies to address those major stressors that we adopted. We modeled it after this modified Maslow's hierarchy, and hopefully what you can see is that at the bottom of that, it's really about basics and safety. And as a chief wellness officer, prior to COVID, I didn't spend a huge amount of time on these sort of basic needs and safety needs because, quite frankly, we had the luxury of not having to worry about them quite so much. But it became clear very quickly in the midst of the crisis that this was squarely within our wheelhouse now, and an area that, thanks to the existence of a robust well-being infrastructure, some of which I alluded to, we were able to rapidly pivot in the midst of the pandemic and start to direct our efforts towards those lower levels of that pyramid, of that hierarchy. I mentioned the importance of communication and the multiple means by which it was important to message out what those needs were and the message, the information. In times of uncertainty, information is a critical means to unload the anxiety that comes from uncertainty. So another way in which we were able to do that, thanks very much to the support of our digital health and communications and web-based teams at Mount Sinai, is we were able to create a COVID-19 staff website for which we had a page, several pages dedicated specifically to well-being staff resources. And so in very rapid fashion, all of which I spoke of in terms of the resources we could provide, the frontline, the psychosocial mental health resources, and the basic needs were all put up onto this site and easily accessible. These are just snapshots of the pages that could be linked to through that landing page, capturing the ways in which our staff could access information about these resources. And you see how they're organized here in terms of basic needs and self-care, with drop-down menus to highlight the most commonly requested resources during the height of the crisis, as well as the mental health and psychosocial supports, which we organized, as you see here, based on whether it was a crisis or an individual wanting support, or a group that wants support, spiritual care, and so forth. I spoke to you of the Frontline relief program that we put in place, providing the care and needs right in the workplace. And this is a wonderful initiative that came out through a partnership from multiple stakeholders within our healthcare system, whereby we were able to set up these interactive, what we call recharge rooms, as well as snack stations right in the places, or nearby, I should say, to the clinical workspaces. And these remarkable rooms, if you look and you see what appears to be a rainforest, that's what it feels like when you enter these immersive spaces that are characterized by sights and sounds, scents, meditative visual elements, which really do very quickly help alleviate some of the stress that you feel on the day-to-day by just taking a short break in these places. And these have been very well received, and we're fortunate that through some philanthropy, we were able to put these in place, and they are now at all of our, either at or in the midst of being ramped up at all 8 of our hospital sites across our health system. So hopefully I've been able to share with you what it is that we went through in the midst of the impact of the COVID crisis at Mount Sinai, as we were facing that really dramatic acute surge. This slide here is it really captures the elements that I spoke of prior to COVID. Making the case for well-being. There's the moral imperative captured by this picture of the emergency room physician who's breaking down outside of the ER where he had been working and had just lost an adolescent in a motor vehicle accident where he's sort of suffering alone, and we see the impacts and the toll that the work takes on the individual. Of course, the business case for investing in physician well-being has been well characterized. There's a regulatory case from our regulatory bodies as it relates to our physicians in training. And of course, the tragic case that we know all too well as it relates to physician suicide, which we've seen even in the midst of this crisis. This was often the elements of the case to be made for well-being prior to COVID. If you go to the next slide, you can see some of the elements that are layered on now in the wake of COVID. And what I have attempted to capture for you here is the enormous stress and strain that our healthcare workforce has experienced in the midst of all this, really documented over and over again in both the medical and lay press, that the scope of the illness and death that a workforce used to dealing with such issues, but because of the scope of what they saw, the impact, we believe, the psychological toll on the workforce is far greater. And so this is definitely a concern for those of us in places such as mine, where we're concerned about the well-being of the workforce. It also has influenced that pivot that I spoke of, where in the midst of the crisis, we began to think about and address basic daily needs as one example of something we hadn't really addressed all that much before. I think also in the midst of the crisis and ongoing, it's the concerns for the mental health of our workforce are rightfully, appropriately elevated at this time. That remains an increased concern, and speaking to chief wellness officers across the country, I know that this remains an elevated concern and sort of an area that has retained heightened focus and priority for those of us in the well-being space. So with the arguments that have existed prior to COVID and the perhaps renewed or increased emphasis placed on the importance of clinician well-being, I place this slide here adapted from a table in the Shanafelt study referenced there, where it provides a sort of a framework for you and your organization to consider what stage of readiness for change you are at in terms of a significant commitment to well-being. And I put this up here not in any way to say to make those who might be closer to the novice or beginner phase more sort of concerned that they're not doing enough. That's not the intent. Really, I put this here to give a sense of where we should all be trying to move sort of along a spectrum. We should all be trying to move towards more of an organizational commitment, because that is truly what we believe is required to have impact, and the consequences of not addressing this in a significant fashion are severe. So it's worth considering the case to be made now more than ever in the wake of COVID, thinking about where you might be at whatever level you practice. This could apply in a way to a single practice, or it could apply to a 40,000 employee organization. It's important to ask where you, your employer, and your organization are at, and think about how you can move forward on this agenda. What we also have here for your reference, and the link is included on this slide, is a toolkit that we at Mount Sinai put together, trying to capture this. So in the midst of all this, we felt that we wanted our experience to be shared, And so we put together this toolkit, which really captures most, if not all, of what I've spoken to as it relates to our experience and the way in which we address it. So this is free to download, and we encourage you to do so. I put this here just also to speak to another important element that we felt was really critical at Mount Sinai, and which I imagine many others have either already begun, have already taken part in some sort of memorialization or are planning it. This was critically important for us. We are about a 45,000 employee organization, very large, 8 hospitals. And as I was saying earlier, certainly the experience in New York City was that nobody really was untouched by this, some more so than others. And we did lose a number of our employees to COVID, and they did cross all disciplines. There were clinical and non-clinical. There were physicians and nurses and folks in staff support and support services, non-clinical spaces. And so this really touched us in a very personal way. And as such, we, with the help of a lot of our spiritual care, palliative care, social work departments, conducted and organized through our system level leadership a virtual memorial service, which was really poignant and well received. We also created the opportunity to have moments of silence for each of our work shifts, including those who work late at night, to stop and reflect on the level of loss that we experienced. And we were able to do those in the middle of the summer. So again, something to consider as it relates to recognizing what we've been through. So now that we've moved into the next phase and have been fortunate in New York City over the last several months to have very low prevalence of COVID, it's almost palpable that we've entered a period of time in which our workforce is really grieving and suffering. And, COVID obviously has had so many layers of impact beyond just the loss of life and the illness. But it's obviously had huge financial implications, social implications as it reflects businesses and livelihoods, family and childcare. The extent to which the layers and layers of stressors are overlapping, particularly at this time, we are aware that there's ongoing need to provide support. And one of the things that my office has done, one of the things that I would argue is a critical role of the Chief Wellness Officer, is to help create coherence around the resources that an institution has to offer, and to share that in a way that is easily accessible and received. And so this infographic is a easy way to visualize all the many existing resources that have continued beyond that acute phase of the pandemic. And so this too we provide to all of our healthcare workforce so that they can know where to go for help. We've also are in the midst of conducting research to try to understand the impact, the psychological impact of COVID-19 on frontline healthcare workers. These are unpublished results that are under review, but as a snapshot, this is how we've captured some of the initial results. We surveyed a sample of our healthcare system, sent out a survey to just over 6,000 individuals, of whom about 60% responded. and we were able to characterize a number of psychological outcomes. We looked at symptoms of, not diagnoses of, but symptoms of depression, anxiety, and PTSD. And so what this captures for you is some of the data that we found as it relates to the real impact. The upshot is that roughly 40% of those surveyed individuals met criteria for symptoms of one of those three conditions. So really suggesting a very significant impact. Now, they were surveyed during the height of the surge and for a few weeks as into the downward slope of the pandemic. We are going to be issuing a follow-up survey in the next month to see how much of this has been a durable impact. But obviously, there's a lot of concern. Some interesting factors we found associated with higher risk for all of these outcomes was self-reported burnout prior to the pandemic, which in my view just validates the need to have organizational efforts directed at unloading burnout. If you have burnout before a crisis, you're more likely to have a significant outcome in the midst of it. Certainly, this crisis had particular impact on work-life balance challenges as schools closed and childcare became a challenge. And then those who had high medical risk were also at greater risk of these outcomes. There were some identified protective factors, such as being married or partnered, speaking to the importance of having a support network. And interestingly, although not surprising based on previous data, the feeling valued and supported at work by your leadership was a protective factor. And this gets back to what I was speaking to earlier about the importance of culture and how, in some ways, particularly during a crisis, that may be even more important than enabling the healthcare workforce to be efficient in the workplace. That's critically important still. But feeling valued and supported by your leadership was a critical element in the midst of all of this. It's my belief that remains critically important. There's a lot of evidence to support that prior to COVID. I think now more than ever, attention to leadership skills and domains of leadership that enhance the well-being of those who report to those leaders is critically important. We at Mount Sinai have set up a Center for Stress Resilience and Personal Growth. This is an outcome of the attention that our group has paid towards the impact of COVID-19 on our workforce, and as a result of that. So we now have a center which provides all of our staff, faculty, and students with no cost support, referral resources, resilience training, screenings, individual coaching, and even some treatment. And anybody can reach out to to the representatives at this center at any time. So hopefully, I've been able to convey to you today what our lessons learned have been in the midst of all this. And there have been many, and I know there will be more. But certainly the approach to clinician well-being required a pivot in the midst of the crisis. And we needed to utilize our well-being resources to address the additional and new and varied stressors that arose in the midst of all this. It's my firm belief that the models, such as the model I shared with you that we adopt at Mount Sinai, that model still applies, and that you can in the midst of crisis apply that and utilize it as a resource for how you want to shift gears a bit, addressing the shifting needs and drivers of well-being in the midst of crisis. So I think, if anything, the places that had existing infrastructure to address well-being were well poised to meet the needs of the workforce during this pandemic. One thing we also have been able to demonstrate through our survey and from what we've seen and heard is that trauma and moral distress will likely lead to significant long-term consequences, including a large burden of PTSD, depression, and anxiety. although more data is forthcoming on that. We do anticipate and will be providing for the ongoing needs to address these psychological consequences. I mentioned the importance of pre-existing well-being infrastructure, and I would just want to hit home again that uncertainty was a huge source of anxiety and stress during the pandemic and remains so now. It's our belief that the best way to address uncertainty is providing whatever information you can in a regular, authentic, transparent way. And even at times when you don't have the answer, to be open about that and say, we don't really know what's coming next, because we don't with COVID, but here's how we're going to be working together to address whatever comes our way. Finally, I'll say that in the midst of this pandemic, everybody can benefit from some increased support, for sure, in the midst of a time like this. Some will benefit from actual treatment. And the good news is that when that is the case, treatment is highly effective. I also will say that and I do always try to end a bit on an optimistic note whenever possible, even in these difficult times, that we have every reason to believe that the great majority of us will get through this and be just fine. Some obviously will need some help, and that's why it's critical to have the resources and to create a culture in which help seeking is normalized. But I do feel that for many of us, we'll look back at this time as a time in which we had a great deal of impact. And in fact, because of our ability to contribute in a time of need, we were able to derive a great deal of meaning from our work. I very much hope that's the case for the great majority of us. And with that, I will thank you for your time. I really appreciate the opportunity and look forward to some questions.
Thank you, Dr. Rip. After these next few slides, we'll transition to Q&A. For additional resources to support your physicians and staff during this time, please visit the American Medical Association website. For general questions or comments, please email action.labs@ama-assn.org. After concluding this webinar, you'll have the opportunity to participate in a 4-question survey. We ask participants to please take 2 minutes to fill out the anonymous survey. Your feedback is important to us as we develop future programming. Now we'll take some time to allow participants to ask questions. Again, please insert your questions in the Q&A box. Please give us a moment while we set up our cameras here. And we'll jump into the Q&A. Dr. Rip, are you able to pull yourself up?
Looks like my video is disabled.
That's okay. We can help on the back end. Okay, do you want to try again now? There you are.
Hi.
Hi, Dr. Rip. I'll be reading the questions off to you now. If any of our attendees would like to elaborate on a question or have a follow-up question, please feel free to go ahead and put it in the chat or Q&A, or you can use the raise your hand function and I will unmute you. With that said, let's go ahead and jump into the questions. We have quite a few here so far. So I'm going to go ahead and start with the first one. Dr. Rip, after SARS, we saw a lot of people leave the healthcare workforce entirely, sometimes through early retirement. Are you concerned about something similar with COVID? If so, how can we think about addressing workforce issues now?
Yeah, great question. And I definitely am concerned. I think I don't have large data sets, to speak to with regards to that and kind of what's happening. And it's probably going to be very sort of geographically specific. I imagine what we'll see in the aftermath in New York City may be different in other places. I do get a sense that, if there were people that were, thinking about retirement in the next couple years, that, this may have kind of pushed the timetable for them. So I think some of the people that already have retired and have left the profession, this may have been what sort of tipped things over. In terms of a general approach, I don't know that there's something necessarily specific to address that concern. I think that is one of innumerable concerns that we're facing, all of which can perhaps best be tended to by a generalized focus on promoting the well-being of the workforce.
Right. So the next question is, what areas do you think researchers can start to focus on now to provide the necessary information and resources to support healthcare professionals when they begin to mentally and physically recover from the pandemic strains?
Yeah, it's a little hard to answer that question and separate it from the research that we're actually doing, because we've thought quite a lot about this. We have a whole research group that's involved in sort of creating the surveys and then gathering the data that I shared with you. So I think my answer has to be sort of what you saw me present there. But probably, if you think about a few buckets or categories of things to measure, certainly what the previous question looked at, I mean, looking at turnover and retention, I think is important. Certainly looking at well-validated measures of psychological consequences are important, just as they were prior to COVID, and there's some similarities but also distinctions as it relates to burnout and other measures of well-being distinct from mental health diagnoses. So I would think about those as related, but perhaps a little separate. I also think it's really important to evaluate the resources you put in place to help people, right? So you can have a beautiful program that looks terrific, but if people are not using it or they don't like it, then it doesn't help anyone. So it's probably a good idea also to if you create a mental health resource or an initiative to promote well-being, to look at utilization and assessment of that.
Mm-hmm. So the next question, Dr. Rip, is, with increased alcohol use during the pandemic, have you done any staff education on the potential risks that come with that?
So specifically as it relates to the uptick in alcohol and substance use, the answer would be no, although I can actually share. So October is National Mental Health Screening Month, Awareness and Screening Month. So as part of that, one of our initiatives just happens to align, it being October, with promoting some normalization around some communications and messaging that aim to normalize help-seeking behavior and destigmatize mental health diagnoses. So through my group, we are in the month of October. We had planned this actually before COVID. We did it last year as well, but messaging around depression, anxiety, substance use, and stress sort of on a weekly basis. So trying to encourage people to again, be aware, to get screened, to reach out. This is whether we had a pandemic or not, whether we saw an uptick or not, these are the intention to normalizing help-seeking behavior goes part and parcel with any well-being program. It was before, it will continue now.
Right, it's important. Has your organization been able to offer flexible work schedules for those with children? For example, expanded office hours, weekend hours?
Yeah, so this is an enormous problem, an enormous challenge. There's a huge amount of, let's start by saying a huge amount of sympathy, and actually, on a personal note, I'm a father of 2 middle schoolers, and so this affects me directly in terms of trying to sort of parent and work at the same time. It's for anyone going through this, it's incredibly challenging. And there's probably some scenarios that are more difficult than others. I know people who have newborns right now. It's just unfathomable to think about how to manage all this. So it's a huge problem. There's not an easy solution, because we need it's dependent on what's happening with schools and in your local communities. It's a complex factor. So it's a little bit of a roundabout question, but nonetheless, a roundabout answer to your question. but nonetheless, we do have a lot of flexibility, actually. Telehealth has afforded that, in fact. So people can do their their patient visits at a variety of times and days of the week. So yes, we have that. It is one approach. I don't know that it's not a silver bullet, because it just won't work with everybody. Everyone's situation is a little bit different, and every large system is kind of tackling this a little bit differently, depending perhaps on what they had to offer beforehand, and what what sort of the portfolio of options that are in front of them. So it's an enormously complex issue, and it's going to vary by geography and health system. So that's the long answer. The short answer is yes, we have some flexibility, which in part was brought about through telehealth. The downside of that, I'll just say, is the driver that can influence well-being, which you can think of as work-life integration. We think of that as a driver that if you're able to integrate them well, it can lead to promote well-being. If there's lots of interference there, it can really erode well-being. And so the flexibility, so it's great that maybe you can do a patient call at 8 p.m. that you would have ordinarily done at 12, and now at 12 noon or whatever, 1 o'clock, and now you're able to care for your kids at 1 o'clock. But it's not great for you to be taking care of your kids all day and then working into the late hours of the night. So it's just that kind of highlights how complex this is.
Right. So the next question is, what advice would you give to health systems that are now beginning to develop mental health services during COVID? For example, are you counseling areas away from high trafficked areas? Have employees expressed privacy concerns?
Yeah. I think the element around high traffic areas, if I understood the question correctly, perhaps had to do with maybe a proactive approach around bringing mental health providers to the places that people are working. So that's definitely been talked about. It was something that we did in the height of the surge. We were able to sort of redeploy some of our mental health providers to proactively reach out and at times be on the units that were very active with COVID patients. And that's an element that a number of systems have employed based on the concern that either in the midst of a crisis when people are so busy, or just as a result of there always being a segment of our community that's not going to seek out help, that maybe if we show up, that'll be better. So I think that element of the question, we had conversations about this, and we weighed in infection control. I think if you have a good relationship with your infection control, you can do this. My guess is that it's less relevant now, although looking at the numbers in general, they're going up in the US. But certainly it's a little less relevant for us because our numbers have come down so much. We kind of don't know what's coming in the fall. We have ideas, but it's unlikely to be like what it was at all, like what it was. So the idea of sending in mental health providers into the hospital to proactively, that's kind of one of the things we've sunset a little bit. What kind of services you put in, I think, depend on what you're experiencing. So probably the most important thing is to do some sort of informal needs assessment to gather, like what are the stressors people are experiencing? Would they benefit from, what services would they benefit from? So, when I presented my slides in terms of how the stressors changed over time, that kind of is the guide for what you bring in. But certainly, in general, increasing access and awareness, COVID or not, is a good thing. So working towards a place where your organization has increased access, and if that requires resources that maybe are hard to come by at this point, there's always work that can be done on raising awareness around existing resources. We know that, in our own institution, when we surveyed our faculty a couple of years ago, something like 30% felt that they would have benefited from mental health services in the year prior. Only about half of them actually availed themselves. And of those that did not, the two main reasons were they didn't have the time and they didn't know where to go. So if things are tight, you can always focus on raising awareness.
Right. The next question is, we learned that needs changed from pre-pandemic to current pandemic, which required well-being resource changes. Looking ahead, do you think the changes you implemented will remain next year, or will that require another shift in focus?
Great question. I refer to it as the COVID pivot. A lot of us are talking about that, that in the midst of the crisis, everyone sort of just, paused and then shifted to direct their focus, towards what was at hand. And so I think we're a little bit in the pivot back stage. We're not going to go back to where we were. It's not going to be business as usual. Some of those shifting priorities will remain. The example I gave in my talk was about uncertainty, right? That was something I wasn't prepared for. I think just I wasn't prepared for the severity of the intensity of the role uncertainty would play in creating stress and anxiety, and so that we continue to see. And there's so many reasons to be uncertain right now that extend beyond one's profession and healthcare system, just the nature of the world, the nature of what's happening, in our country. There's so much going on right now that's uncertain. So that, an attention to that will remain. And I mentioned, through messaging and so forth. But yeah, that for some time, I think, will remain a shifting need and priority that we'll focus on, as an example.
Okay. Okay, so the next question is, it says, I'm curious if anyone has explored the tools and practices of narrative medicine, commonly used to improve the patient experience. These empathy and feelings forward tools could provide relief for HPVs.
Yeah.
For HCPs, I apologize.
Right. Yeah, I'm not sure what it can do for human papillomavirus, but yeah.
That is not what I meant.
Yeah. So, narrative medicine is a great tool. I am definitely a proponent of it. In fact, we at Mount Sinai we have a cadre of narrative medicine expert facilitators who we support through my office and deliver as one tool on kind of what I think of as a menu of offerings. I put that in sort of the individual resilience category, or self, sort of personal factors category, because I do think that for individuals that are so inclined to derive benefit from writing about their experience, it's a great option. I think there is an emerging data on the impact of narrative medicine here in New York City. Just up the block from us is Rita Sharon, who some sort of ascribe as sort of the founder of the field, and so I think it's we're fortunate to know people who have those skills. So we offer it. I think their evidence is emerging in terms of its role in well-being. I mean, I think it makes sense that for some individuals. I do think it's a highly specific type of offering. So for someone who just doesn't like to write or always hated writing in school, to make them sit down and write about it, write about certain things, may not be for them. Just like mindfulness may not be for some people, but we know that it's great for others. So that's how I kind of approach narrative medicine, but I'm definitely a proponent and a fan.
Okay, great. So this next question has multiple questions within it, so I'm going to try and take it one by one. It says, regarding the recharge rooms, which look like a great resource, how do you staff them to make sure they are stocked, cleaned, and generally maintained? Is it you, your staff, or do you have institutional partners like environmental services to help?
Yeah. So the recharge rooms are amazing. That was another thing that I wasn't sort of prepared for the idea. And I remember actually one day when I was redeployed taking care of COVID patients, I had been having an email correspondence with the person who kind of is the genius behind the recharge rooms. And they said, you should just come down and see it for yourself. And so I just did that. And it was amazing. Like it really, in a matter of minutes, kind of just, put me at ease. So, in the midst of the crisis, when and everyone had sort of an all hands on deck attitude, everybody was working well beyond their usual means. And so that's kind of how those rooms function. But that's an example of something that will remain. beyond the pandemic. We now have, and in fact, we're expanding them. We're making sure that they reach all of our hospitals in our system. And one of the challenge, sort of the challenges and the opportunities of being a chief wellness officer. My job is really to be the one that provides expert guidance in measuring the well-being of a healthcare workforce, and then consultation to a variety of stakeholders about how to steer the ship, if you will, the ship being the direction of the healthcare system, in a way that promotes professional fulfillment and meaning in work. And so this is an example where I can't. I actually have a limited team. They can't be out there at 8 hospitals managing the recharge rooms. So we need to partner with the local leaders. And fortunately, they are bought into this. So we need to partner with them so they can provide those services needed to make sure the recharge rooms are delivering what they can in a safe and clean way.
That's great, Dr. Ripp. And then a follow-up question is, to get the sensory resources like you offer, how much money should a site attempt to raise to create a similar space?
So I think the question is about about the recharge room, like the
Yes,
resources
yeah.
needed. Yeah. So what I will say is, if you're interested in the recharge rooms, feel free to email me, and I can direct you to the point of this. I am not a person who knows how to, create a rainforest in what was once an unused space. But fortunately, I know the person who does have that brilliant skill. But the bottom line is, it's probably not. My guess is it's not going to cost as much as you might think. And I don't want to give the wrong answer to this question. So I would just say, if of interest, reach out and I'll connect you to the person who can give you more specifics.
And if it's okay for me to share your contact information, Dr. Ripp, I can follow up and put that out there.
Sure.
A couple more questions for you. How did you manage communications? For example, too much versus too little. We've heard that some individuals are terribly overwhelmed by the amount of communications that they received at the beginning of the pandemic. Is there some sort of balance? How did you achieve this balance?
We think about this question all the time. What's the right amount of messaging? What's the sweet spot where we're there, we're here for you, we care about you, you're hearing about what's going on, and it's transparent, but it's not annoying, or it's not absent. It's got to be. So we're constantly searching for that sweet spot. We also, I have the ability to send out a message from my office, but there's also, like any large healthcare system, there's a marketing team, right? There's a team that manages communications. In the midst of the crisis, I was fortunate to partner with them, and our voice was considered valuable to them. So we were able to influence the messaging going out. In the midst of the crisis, it was like many of you, I imagine, at the beginning, we recognized, oh my God, everybody is sending way too much information. We need to get control of this. And there was a strategy that developed where there was a single daily email and other weekly town halls and so forth. And I imagine many of you had similar experiences. So that was controlled by kind of the communications apparatus of the system. But now in the current phase, as we continue to send out messaging, we think about this a lot. What's the right amount? And I think you got to just keep thinking about it, because it's hard to get it just right. You won't get it just right for everyone.
Yeah. We're almost at the top of the hour, so I'm going to give you one more question, and then we'll wrap up. Do you have any advice for systems that don't currently have a CWO or head of well-being? How can we address well-being if we don't have a leadership position ready for this role?
Yeah, so what I would do is direct you back to the slide where I sort of showed the spectrum of stages of readiness. And the answer to the well-being of a system is not get a chief wellness officer. And in fact, if you get a chief wellness officer and that individual is not empowered to do things, and doesn't have a seat in the room where they're able to steer the ship, as I spoke, then it doesn't matter that you have a chief wellness officer. What's more important is that wherever you are, you take stock of where you think your system is at in terms of its readiness to move forward in addressing well-being on an institutional level. And then advocate to move along that spectrum towards the more advanced kind of expert phase. If that includes a chief wellness officer, great. But more importantly is sort of that commitment, dedication to an institutional approach. So thank you.
Thank you so much, Dr. Rip. This was wonderful. We greatly appreciate your time and expertise. To our participants, thank you again for joining us today. We hope to see you in another one of our upcoming webinars. Thank you all. Take care.
Thanks, everyone.